Okay, class. So we are going to start. Can you people hear me? Can you people hear me?
Yes.
Yes, we can hear you.
You just speak. Okay. Let's begin our class. Okay. Okay, let's start. Which of the following is the most likely to be involved in the pathogenesis of this patient chest pain? Always start from the last line. Okay. Then move on to the options. Decreased endothelial expression of endothelin 1, granulomatous inflammation, okay, hyperactivity, increased cycling, ulceration, okay. Now comes back to the let's see if there is any objective finding in this. Now comes to the objective part. Any lab findings, any chest X-ray, any imaging findings. Then we will move on to the subjective part of the question. ECG reveals ST elevation in lead 1 AVL V46. Patient is given nitroglycerin, improves her symptoms. Percutaneous coronary angiography, on angiography, no obstructive lesion. Okay, angiography, no obstructive lesion. Now move on to the subjective part of the question. Okay, age 34, department due to chest pain. Okay, okay, 34 years age. ECG changes, only ECG changes. Angio, no obstructive lesion. Okay, chest pain. Now you have to find the diagnosis which can explain which can explain all the abnormal findings in this patient. You have to find a diagnosis or an answer which is much more consistent with all the possible abnormal findings in this patient. Okay. The patient found that she went to bed feeling well, wake up in the morning, it will be severe crushing chest pain that radiated to her left arm. Chest pain radiating to the left arm. Crushing chest pain. Okay, so it is not a pain of pericarditis or something like that. We know the pericarditis pain or the aortic dissection, they are much more sharp pain. It is a severe substernal crushing chest pain that is much more linked to the heart condition. Okay. History of original migraines. History of migraine. Okay. Does not use tobacco, alcohol, or illicit drug. Blood pressure is 150 by 100. Hypertensive pulse is elevated. Okay, respiration normal. On physical examination, the patient appears distressed and diaphoretic. Distressed and the pain distressed and diaphoretic, and the pain resolves after a symptoms improve with nitroglycerin. Okay. Granulomatous inflammation, option number B. Option number B response is consistent with what diagnosis? Granulomatous inflammation of the aortic median. We have done a lot of question on vasculitis yesterday. What type of vasculitis have granulomas? What type of vasculitis has granulomas?
Takayasu.
Takayasu.
It's
Takayasu.
giant cell or
Taka-
yeah.
Takayasu have a Takayasu arthritis has granulomatous inflammation. Okay, it is much more common in young women of Asian descent and sometimes develop angina due to chronic. However, limb claudication lymph claudication, there are going to be much more constitutional symptoms as well, fever, fatigue, that are much more common presentation. Involvement of coronary artery, Takayasu arthritis, other name is pulseless disease. Okay. So, involving of the coronary artery is much less common, and the involvement of the bigger arteries, subclavian artery, radial artery involvement, that is much more common presentation. And you are going to see constitutional symptoms as well, fever, fatigue, which are not present in this patient. Okay. Option number A and D. Endothelium 1 is a vasoconstrictor or a vasodilator. In the pulmonary,
Vasoconstrictor.
yes, in pulmonary
Vasoconstrictor.
and prostacyclin. What about prostacyclin?
Vasodilator.
Vasodilator.
Okay, so if you decrease expression of endothelium 1 and increase expression of prostacyclin, what will happen? Vasodilation or vasoconstriction? Increase endothelium. If you decrease the expression of endothelium 1, decrease the endothelium 1 and increase prostacyclin. What will happen? Vasodilation or vasoconstriction?
Vasodilation.
dilation.
Vasodilation. The symptoms we are seeing in this patient are due to are, are present due to a less blood flow or more blood flow. Due to a lesser blood flow to the heart muscles or a more blood flow to the heart muscles.
Lesser. Lesser blood
Less.
flow.
Lesser. So vasodilation does not cause this symptom. Rather than if there in option there is vasoconstriction, then you will go for option number A and D, right? Because both of these are going to lead to vasodilation, and vasodilation is going to improve the symptoms, right? Okay. Now there's option number C and E. Option number E, ulceration of thin atheromatous fibrous cap. That represents what condition? Okay, tell
Atherosclerosis.
atherosclerosis. Which line in this whole question eliminates option number E? Which line in this whole question eliminates option number E?
That there
No
is
obstructive
practically.
lesions on PCI.
Yes,
Yeah.
yeah,
Yeah.
yes. The angiography that shows there's no obstructive lesion eliminates option number E. So the only option that is making sense here is option number C. Option number C, diagnosis. What type of angina?
Prince metal angina.
Prince metal
Transmitter.
angina, vasospastic angina, transient ischemic angina.
Also, there is the angina that happened during sleep. So it represents
Yes. Transient,
Prince metal.
transient ischemic ST changes on ECG. Okay, there ECG changes in our patient, right? There are ECG changes in our patient. Only ECG changes, but no changes, no troponin elevation, no obstructive lesion, nothing. Okay, only ECG changes. That type of angina is called vasospastic or Prinzmetal variant. Okay, occurs at rest due to secondary to coronary artery vasospasm. Okay, so this is a case of Prinzmetal angina, vasospastic angina, in which you are only going to see ECG changes. Okay. Okay, let's move on to the next one. Which of the following is the most likely to be predominant cell type in these lesions on light microscopy? Okay, start from the last line. Give a read to the whole options for 1 second. Okay, then see if there is any objective part of the question. Okay, then move on to the subjective part. Okay. Group of forensic pathology are analyzing tissue samples of adolescent age 13 to 18 to study the aging process. Autopsy of 14 shows minimally raised on the inner surface of the abdominal aorta. Several minimally raised yellow spots on the inner surface of the abdominal aorta. Okay, during the autopsy, and there was no family history of cardiovascular. Okay, raised yellow spots on the inner surface of the abdomen. They are not during autopsy. In normal, there was no family history. Okay, what are those yellow spots indicative of?
Home cells?
Fatty streaks.
These are fatty streaks. Fatty streaks, yes. Fatty streaks are seen in what?
Atherosclerosis.
Atherosclerosis.
Fatty streak formation. And during the fatty streak formation, during the early stage, what cells are most prominent?
Macrophages.
Macrophages. Lipid-laden macrophages are the most prominent when there is a fatty streak formation. Okay, in the early stage there is a macrophages, and later on you are going to see recruitment of T cells, smooth muscle cells, migration, fibroblast migration to that. But in the early stage, the predominant cell types is going to be in the fatty streak. In the fatty streak, the predominant cell type is going to be macrophages. Okay,
Macrophages.
so right answer is the macrophages. Okay, it is a fatty streak. Very good. These are the early changes of atherosclerosis. A 22-year-old woman comes to the office due to worsening dyspnea. So they will also explain low-grade fevers. Okay, the patient has low-grade fever, weight loss, syncope episode, shortness of breath when sitting, improves when lying down. Okay, positional syncope episodes. Lungs are clear. Cardiac auscultation reveals a low-pitched mid-diastolic rumble at the cardiac apex. Okay, ECG reveals left atrial enlargement. Shows a large pediculated mass in the left atrium. Mass in the left atrium, positional syncope episode. They are a the murmur sound resembles what? Mitral stenosis, mitral regurgitation. What murmur?
Mitral stenosis.
Mitral stenosis at the cardiac apex by diastolic murmur. At the cardiac apex, we heard mitral murmurs. And if it is a diastolic murmur, then it is going to be mitral stenosis. Okay. Okay, there is a mitral stenosis murmur. There is a mass in the atrium. There is a left atrial enlargement as well. There are constitutional symptoms as well. And there is positional syncope episodes as well. Okay, what histology of that mass is going to reveal what? Is it a infective endocarditis?
No.
No, it is not
Atrial
infective.
myxoma?
Yes, it is atrial myxoma. Okay, it is atrial myxoma. Okay, okay. It is not the most common type of the most common primary type of heart cancer is in adults.
Rhabdomyosarcoma.
Is atrial most common type of heart cancer is
Myxoma.
Myxoma. Yes.
most common primary tumor is
Metastasis.
myxoma.
Metastasis.
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 Very good. And
Metastasis.
most common primary type of tumor in the children.
Rhabdomyosarcoma.
Rhabdomyoma.
Rhabdomyoma.
Very good. Okay.
And tuberous sclerosis.
Our patient is an adult, right? The constitutional symptoms are present in our patient, right? Fever, fatigue, weight loss, all of these present, right? Mass is in the left atrium, right? Okay. Associated is our patient have multiple syncope episodes, right? Does our patient has early diastolic tumor plop sound as well, mimicking the mitral stenosis, right? Okay.
Yes.
The histology would be a gelatinous material, myxoma cells immersed in the gags. Okay. Myxoma cells immersed in gags. Okay. So what would be the right answer? Gags are the ground substance which form the extracellular matrix. Okay. So what will be the right answer?
D.
D.
The scattered cells within a mucopolysaccharide stroma. Okay. Okay. Which of the following ultrastructural changes would most likely indicate irreversible myocardial injury? Okay. Irreversible myocardial injury. Okay, we have to find the ones which tell that the cell injury changes are irreversible here. Okay. 54-year-old man comes due to a retrosternal chest pain of 30-minute duration, complains of sweating, mild dyspnea. The pain is relieved with nitroglycerin and decreases significantly with nitroglycerin. Has experienced several similar episodes of the pain over the last 12 hours, all of which is in the patient is seeing the pain is of what? Is it of MI? Is the pain is of MI?
Yes.
Yes, okay. Now you have to tell me which of these changes is going to be irreversible. The cell injury changes which are irreversible, which are reversible. Okay. Uh, Can someone is can you please someone instruct Hamza? Hamza, can you? Okay, thank you. Okay, let's come back to our question. Okay. Okay. That is the nuclear changes. Is the nuclear changes a nuclear changes chromatin clumping, the disaggregation of nuclear granules? Is this in the option number D? Is it reversible or irreversible?
I think it's reversible.
Reversal.
It is reversible. Very good.
Reversible.
Option number B. Is it reversible or irreversible?
Reversible.
It is going to be reversible.
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 Option number A.
Irreversible.
Reversible or irreversible? Option number A.
It's reversible.
Reversible.
Reversible. Okay. C, E, and F. Hmm. Option number F. It is going to be reversible or irreversible? Option number F.
Reversible.
Reversible. Okay. Now comes to option number C. Option number C.
It's irreversible, I think.
That is going to be irreversible. Okay. When the damage has been transferred to the mitochondria, then it is going to be irreversible. Okay. Some changes of the nucleus are reversible, some are irreversible. Okay. Option number C is for irreversible. Okay. At what point on the graph does the affected portion of the stop contracting? Okay, at what point rapid loss of function, myocardial cells are non-contractile after can you see my screen after how many minutes?
1 or 2 minutes.
1 to
One
1
2.
to 2 minutes. Now tell me what will be the answer of this question.
B.
B or A?
A.
A.
I think
1 to 2 minutes. B represent 1 to 2 minutes or A represent for 1 to 2 minutes?
A represents 1 to
A.
2.
Good.
I
Yeah,
think
and B,
A.
5 minutes.
I think A.
yes, and B represent 5 minutes. So what will be the right answer? A.
Yeah.
Okay. Which of the following pathology state is most likely to be present in this patient? Okay. Start from the last line. Move, then move on to the options. Then move on to the objective part. Then move on to the subjective part. Okay. Okay. 52-year-old man, periodic substernal chest pain, periodic substernal chest heaviness. A pain is precipitated by exertion. Okay. And the pain decreases by rest. History of hypertension, smoke cigarettes. Lungs are clear, no heart murmurs, no peripheral edema. Which of the following state? Okay. There are no murmurs and the And there's exertional chest pain in a classic distribution pattern that is resolving with rest. Okay. Okay. Option. How much percentage of the a, a of the coronary artery must be obstructed to produce to produce angina symptoms?
70.
70%.
More than 70.
70 or more than 70. So option number A is eliminated, right? Option number C leads to what condition? Option number C,
MI.
MI.
Mm.
Does our patient has MI? No, right? The patient has only angina symptoms right now. Okay, option number D. Why we eliminated option number D?
Vasospastic
And it
angina.
occurs at rest. It occurs at rest. Not,
Mm.
you can see in the question, the pain is precipitated by fast walking. There is a clear relationship between exertion and the pain, right?
Mm.
That's why I eliminated option number D. Okay. So which one is going to be the right answer?
B.
B. And option number E also is going to be cause a NSTEMI. It is option number E is going to cause NSTEMI. Okay. B is the right answer for the patient is suffering from stable angina. Usually secondary to atherosclerosis, exertional chest pain, classic distribution, resolving with rest. Does our patient pain resolves with rest? Yes. Okay. So on to the next one. Which of the following is the most likely cause of this patient pain? See the option, then move on to the. Okay. Now let's see the pain pattern here. Okay. 29-year-old man brought them retrosternal chest pain, for the past hour, agitated, restless. Okay. Now let's see all the abnormal finding in this patient and then try to make a diagnosis which can justify all of these findings or can explain these findings. Temperature is low grade fever. Okay. And now who's who is sharing the screen right now?
No, doctor.
Someone is sharing the screen and due to which I can no longer be able to share my screen. Its name is Fakir George. Eh, Fakir George, can you please stop sharing your screen? Okay, let's move on to our question. Okay, so the patient has a retrosternal chest pain, agitated, restless. Blood pressure is 180 by 106, and in the right, and hypertension, very high blood pressure, pulse is very high. Okay, agitated, restless. Physical examination shows bilateral dilated pupil. Okay. Okay, retrosternal chest pain. Age is what is the age of the patient? It will help you a lot. What is the age?
29.
29. Do you think in a 29-year-old man you are going to see atherosclerosis symptoms?
No.
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 Okay. The blood pressure is 180 by 106. Dilated pupils. Dilated pupils. ECG shows sinus tachy and ECG shows ECG changes are present. Chest X-ray normal. Normal mid-external cardiac enzymes are normal. Cardiac enzymes normal. Sub is nitroglycerin and benzodiazepine relieve the symptoms. Okay, is the pain is of acute pericarditis? What type of pain is of acute pericarditis? Does the acute pericarditis pain relieved with nitroglycerin?
No.
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 No. And acute pericarditis pain is sharp, right? Right? And then there's a normal mediastinum and cardiac silhouette. Okay? Okay. Is the pain of is the aortic dissection would have a normal chest X-ray, normal mediastinum, and cardiac silhouette in a aortic
No, sir.
dissection pain?
No.
No.
No. And how are you going to explain the dilated pupils in the aortic dissection, right? Okay. If the answer is C, if the answer is coronary artery thrombosis, what specific line in this question eliminates option number C as a diagnosis? What specific line?
ST segment depression.
ST days and
Heart-
STEMI cardiac enzymes are normal. Cardiac enzymes are normal. In NSTEMI, there is ST depression and there is coronary thrombosis. But cardiac enzymes will not be normal in whether it is STEMI or not. Okay. If there is coronary artery thrombosis leading to the STEMI, then the cardiac enzymes will not be normal. That's why we have eliminated option number C. And again, how does it going to explain the dilated pupil? If you are going for MI, how are you going? Okay, now comes to option number D and E. Which one is going to be the right answer here?
D.
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 Okay, okay, D. Okay, now tell me what will be the cause in a young patient? In a young people, dilated pupil, 180 by 106 blood pressure, there's ECG changes with no cardiac enzymes.
Cocaine
Why this
used.
cocaine use? Okay, the patient is using some type of a drug which are leading to the which are causing the coronary vasoconstriction. Okay, and due to which you are going to see this. Okay, and we know that vasospastic angina can be a in vasospastic angina, cocaine can cause a vasospastic angina. A cocaine, amphetamines. Okay, see it with calcium channel. Okay. So the answer is coronary artery vasoconstriction. Okay, it is. Okay, so we did the question. What is the cause of a vasospastic angina here? What is the cause in our first question?
Hypersensitivity of
Hmm?
the muscle. Hypersensitivity of the smooth muscles.
History of migraine, so use of triptans.
Yes, use of the triptans. Very good. Okay, use of the triptans.
Mhm.
That's why we are seeing that symptoms in that patient. Okay, let's move on to the next one. Cardiac catheterization will most likely show which of the following. Okay. 55-year-old man is brought to the emergency department due to severe substance pain is what is the age? 55. Okay. Okay. Substernal chest pain. Okay. Started as middle and chest discal several hours ago, but his progress better. People could not fall asleep. Sibling without is nitroglycerin does not relieve the pain. Nitroglycerin does not relieve the pain. This line that the nitroglycerin does not elevate the pain, does not remove the pain, eliminates what diagnosis?
Stable angina.
Yes, it eliminates stable angina. Okay, there is ST elevations. ST elevation changes in the ECG. Okay, okay. So it has a option as we have eliminated option number as we have eliminated stable angina. Which option is going to be eliminated?
D
Which option
option.
represents yes?
A and
B.
B.
Option number yes,
Both are.
Yeah, A and B both.
yes. Option number A represents principal angina or vasospastic angina. Okay. Option number B represents the stable angina. Okay. So both of them are going to be eliminated. Okay. And option number D is also eliminated. Okay. It is not principal angina. Okay. Okay. Now we are left with C and E. Okay, I have told you in the previous question that option number E represent what diagnosis? Option number E represents what diagnosis?
And STEMI.
Stable.
And STEMI. Option number E represents and STEMI. Does our patient has and STEMI or STEMI? The ECG changes. What are they?
Yeah,
ST
STEMI.
elevation. Those are
STEMI.
STEMI. Those are STEMI.
Mm.
Okay. There is a fully obstructive thrombus, not partially obstructive. If it is partially obstructive, then we are going with the STEMI. Okay. 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 ST elevation. On exertion, no elevation, elevated transmural sub. There's one more thing that you have seen the pathological Q waves and the ST elevation. Okay.
Old MI.
Yes. And there's ST depression and T wave inversion. Our patient has ST elevation and deep Q waves, pathological Q waves. Okay. Okay. Let's move on to the next one. The first step in the pathogenesis of this patient disease most likely reveal involve which of the following. Okay. Cardiac catheterization shows 80% occlusion of the right coronary artery and 60% occlusion of the left coronary artery. Okay. 60-year-old man comes to the office with a 6-month history of exertional chest pain that remits with rest. Age 60. Age is 60. See, the two questions we solved of the vasospastic angina, their age is very young. See, now you can see the pattern. The only thing you need to learn is to how you can pick up the patterns of the disease. Age 60, there is exertional chest pain that remits with rest. Exercise test is positive for inducible ischemia. Cardiac shows 80% exclusion of the Khalil. Can you turn off your mic? Things. Okay. So there's a 80% exclusion of the right coronary artery, 60% exclusion of the okay. What cells are the first one to involve in the atherosclerosis?
Endothelial dysfunction.
The first thing that is going to be happen, endothelial dysfunction. Damage endothelium. Then there is going to be fatty streak formation leading to the involvement of the macrophages. Okay, so the first the cells that are going to involve is the endothelium, right? Then macrophages, and after the macrophages, then you are going to see smooth muscle cell migration and fibrous plaque formation. Okay, okay, so the answer will be endothelial cells. Okay, okay, let's move on to the next question. The absence of myocardial necrosis and scarring despite. Okay, then just give me a minute. Just give me a minute. Okay, okay. Okay, so okay, you people can see my screen, right? Okay,
Yes, doctor.
let's okay. The absence of myocardial necrosis and scarring despite vessel occlusion in this patient can be best explained by which of the following features?
I think we can all rejoin this call in case Khalil is not listening to us.
Okay, let me call Dr. Ahmed so he can, because he has the admin access, so he can maybe stop the Dr. Just let me
Yeah.
call Dr. Ahmed.
If not, we can all rejoin the call. It will be easy also.
Class, I have asked Dr. Ahmed to do something about it. Just give. Okay, so now his mic is muted. Let's start again. Okay.
Hello.
Yes.
Okay, so one thing which I want to mention, please, that we have keep your mic open in order to have a proper discussion, right? We do not want like this kind of disturbance, and like to be honest, all of us are like grown-up doctors, so please just take care of that, okay? It won't happen after it, please. Thank you so much.
Okay, the absence of myocardial necrosis and scarring despite vessel occlusion in this patient can be best explained by which of the following features of the occluding plaque. Okay, 69 lipid-rich core, low calcium content, ostial location, in fibrous cap. Okay, active peripheral inflammation. Okay. Okay, so you have to tell me which of these feature is related with increased risk of complications in the atherosclerosis. Okay, which of these is going to be linked with a decreased risk of inflammation, decreased risk of complications, complications with atherosclerosis. Okay, okay. Active peripheral inflammation. Is active peripheral inflammation is going to be linked with increased risk of complication or decreased?
Increase.
Increased.
Increase.
Increased. Atherosclerotic plaque with inflammation are more unstable and are more likely to rupture. Okay. A option number F, thin fibrous cap. Thin fibrous cap, are they more stable or unstable?
Unstable.
Unstable. Unstable.
They are going to be much more unstable. Okay, thin fibrous cap, they are going to be much more unstable. Okay, thin fibr a lipid rich core, the one which have a lipid rich core, are they going to be more stable or unstable?
Unstable.
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 Yes, they are also going to be much more unstable. Okay, okay. Now C, D, and F. Ostial location. Ostial location is going to be linked with more risk of complication or less risk of complication.
More.
More.
Easy.
Okay. Ostial location means that, yeah, this is a coronary artery. If it is located, the atherosclerosis is here, that means a ostial location. If it is there, okay, ostial location mean that at the opening of the coronary artery. If the atherosclerosis plaque is present at the start, coronary artery, you are going to see much more risk of complications. Okay, now we are left with C and E.
E. Slow growth rate.
Okay, so why don't you think that C is the right answer?
I think high calcium it will make the more patent atherosclerosis.
Calcium
The low,
content show the complications risk.
Mm.
okay, so
Higher the calcium, higher is the complication.
higher is the
Yes.
calcium, higher the
Okay.
yes, higher is the
Yeah.
calcium calcium content correlates with the risk of complication. Higher is the calcium, higher is the risk of complication. Okay, so low calcium, low risk. Okay, and low calcium, low risk, but as compared to slow growth rate, that slow growth rate is going to cause much lesser risk as compared to calcium in determining the risk of complications. Okay. Okay. Special total artery calcium content correlates with the total atherosclerotic plaque burden. Calcium scoring by cardiac CT scan is sometimes used to estimate this. However, low calcium content with an individual plaque may decrease stability of that plaque and increase the likelihood. Our low content as well. Okay. With an individual plaque may decrease the stability. Okay, low calcium content also decrease the stability of the plaque and increases the likelihood of rupture, along with high calcium as well. Okay, both very high calcium and very low calcium are related with increased risk of complications. Okay, that's why we do not go for option number C. Mm. Which of the following promotes the formation of these tissue indicated by the arrow? Okay.
Amyloidosis.
So
Isn't this red? So red shows capillaries.
yes. Uh, okay, let's first, which of the following options? Let's see the option. 62-year-old man dies in his sleep. A patient had a history of type 2 diabetes mellitus, hypertension, and he smoked a pack of cigarettes daily for 25 years. Pack of cigarettes daily for 25 years. His adherence to medical care was poor. Autopsy is performed and a histological scan section of the photo is shown. Okay. So this is the photo. So what tissue can you see in this patient?
Scar.
The right side
That's
it
a,
is normal
It's
cardiomyocytes and the left side
fibrosis.
is fibrosis.
Fibrosis.
this is
Fibrosis.
fibrosis. Remember that pink photo we have seen in a histology question, the pink photo. Okay, this is fibrosis. This is a fibrotic scar. This is a fibrotic scar. Okay, this is the photo. This is the photo is asking us about the fibrotic scar which have developed in this patient. Okay, post MI, the patient has developed a scar tissue. Okay, and in the development of scar tissue, in the development of fibrosis, remember the idiopathic pulmonary fibrosis. In idiopathic pulmonary fibrosis, what interleukin is involved?
It's TGF beta.
TGF beta. TGF beta is directly involved in the formation of fibrosis. It stimulates the fibroblast to cause fibrosis. And in the scar tissue, we know that the most there is fibrosis, and the cells which are responsible for fibrosis are fibroblasts. And what cells stimulate the fibrosis due to scar?
Macrophages.
TGF beta. Okay. Okay. Interferon beta. Okay. So the patient has a scar tissue. Okay, you can see that in the these are the different photos. This is the normal one. Then you are going to see this photo in which there is going to be involvement of neutrophils within the cardiac myocytes. Then you are going to see macrophages, and then at the end you are going to see this photo. This is a completed scar. Okay, and in scar there is fibrosis, and in fibrosis we know what cells are involved, what interleukin is involved, TGF beta. That is the same interleukin against which we used antibody for in the idiopathic pulmonary fibrosis. Okay. Okay. TGF beta. Okay. Okay. Which of the following is most likely predispose this patient to be observed to the observed cardiac finding? Okay. Sixty-four was discharged from the hospital 4 days ago due to the emergency department due to chest tightness and severe shortness of breath. During evaluation, the patient becomes unresponsive and goes into cardiac arrest. Despite appropriate life-saving measures, there is no return of spontaneous circulation, and she is pronounced dead. Okay. Autopsy. Okay. On the photo, what is the age? 64. Shortness of breath, chest tightness. Unresponsive died due to cardiac arrest. Cardiac arrest. Okay. Which of the following most likely predispose this patient to the observed cardiac finding? Okay. Can you tell me what is this photo? What you can see in this photo?
Free wall
Slit
rupture.
like free wall rupture. Slit like.
Yeah, you can see that the wall of the cardiac tissue is ruptured. Okay, there is a free wall rupture of the left ventricle. Okay, you can clearly see that the wall is ruptured at the left ventricle side. Okay, free wall rupture occurs uh, at what time frame after post MI? Free wall rupture complication.
5 to
3
14.
to 4, 5 days, I think.
3 to
5
7
to
days.
10 days. 10 within 10 days.
Okay, 3 to 4, you are going to see free wall rupture. Okay. 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 And so now comes to the cause here. Recent viral infection leads to what heart complication?
Dilated cardiomyopathy.
Pericarditis.
Dilated cardiomyopathy.
Myocarditis or pericarditis?
Pericarditis.
Recent bacterial pharyngitis, option number D.
Rheumated.
Myocarditis. Post means you can say streptococcal
Rheumatic
or
fever.
post myogenic rheumatic fever.
Rheumatic.
Prolonged alcohol consumption or the repeated blood. Repeated blood transfusion.
Hemochromatosis.
This probably was probably what caused the heart.
The repeated blood transfusion can lead to iron overload, which can lead to the hemochromatosis, and hemochromatosis can cause both dilated and restrictive cardiomyopathy.
Restrictive both.
Okay, so the answer is that the condition we have free wall rupture can occur due to MI, due to a transmural cardiac infarct leading to the free wall rupture. Okay, within 5 days or up to 2 weeks. Okay. Which of the following is most likely mechanism of this patient's syncope? Okay, so age is 24. In a 24 year, and in this 13-mile half marathon, 13-mile half marathon, the patient felt lightheaded and then passed out. He immediately placed in a supine position. What changes when you put the patient in supine position, and that position is improving the patient's symptoms?
Preload
Increase.
increases is
Yeah.
like how come then?
Yeah, it
Leg
increases the
raising,
venous.
number.
Yeah, leg raising increases the venous return, right? Okay, so the patient, so that's mean the patient, if the patient abnormality is getting treated by increasing the preload of the heart, that's mean there's clearly a relationship between the preload and the abnormality in this condition, right? That's why it is getting improved when you immediately place the patient in a spine position. Okay. Okay, so the patient is a 24-year-old. He went on a 13-mile marathon. That is very important here. Okay, and after the end of the marathon, he collapses. His blood pressure drops to 98/56, but there are no ECG changes or something like that. And there's no chest pain as well. Okay, and when you place the patient in a spine position, the patient regains the consciousness. What is happening in this patient?
Dehydration.
Why? Yeah,
Dehydration.
dehydration. Yes, due to the dehydration in the patient, it collapses, and because the cause is dehydration, when you put the patient in a spine position, like if the cause is MI, if the cause is MI, does putting the patient in a spine position improve the patient's symptoms?
No.
No.
No, right? Because the cause is dehydration here, because the venous return has decreased, and when the patient was running, there is muscle contraction leading to the compensatory increase in the preload. But when he stopped running, the muscle stopped contracting, and because he has lost large amount of fluids during the marathon, he suddenly collapsed. Right? What will be the answer then?
A.
It is cardiac because how come it's create symptoms by increasing the preload or by giving the beta blockers, decrease the contractility.
Yes, he went on a 13-mile half marathon. That's 13-mile half marathon. Which of the following best explain the changes in the cardiac contractility and valve motion seen in this patient? Okay, which of the following? Okay, what is happening in this question? 58-year-old man, dyspnea, chronic exertional angina. Okay, evaluated for coronary revascularization, history of hypertension, type 2 diabetes mellitus, hypercholesterolemia. With the exception of a fourth heart sound. Okay. Hypokinesis of the left end of the anterior wall of the left ventricle and left ventricle ejection fraction has dropped to 35%. Undergoes cabbage. Repeated echocardiogram 10 days after the shows the hypokinesis is no longer evident and left ventricular ejection fraction has increased to 50%. Okay. Okay. Okay, so in the question he has said that there is first the left ventricular ejection fraction has decreased, then he undergo cabbage, and after the cabbage, the hypokinesis is no longer there, and left ventricular ejection fraction has improved from 35% to 50%. Okay, so why just to explain why the cardiac contractility can be explained by what phenomena? Is it can be explained by the
Explain,
reperfusion? Is that can explain by
explain
the
to start.
reperfusion?
No,
No,
not.
it's immediately, after PCI or some other things, but not after cabbage.
Yes. Okay. Ischemic preconditioning. Do you think the answer is ischemic preconditioning?
No, I think.
What
Sorry,
does
what
it?
is ischemic preconditioning? Yeah, in ischemic preconditioning, repeated episodes of angina prior to the MI can delay the cell death after complete chronic occlusion because now the cells have become much more adapted to the ischemic condition. Okay, if the cells have faced the ischemic conditions like angina much before the MI, they have become much more adaptive to these ischemic condition. They have already adapted the changes needed to survive for a longer period of time as compared to when they have not faced angina prior to the ischemia. This is called ischemic preconditioning. Okay, post infarction no. Okay, now comes to the hibernation and stunting. Okay, stunting is transient reversible left ventricular systolic dysfunction after brief acute ischemia. Okay, and what is hibernation? Left ventricular systolic dysfunction which is present in our patient in the setting of chronic ischemia. Okay, up till now this statement is correct. Potentially reversible with myocardial reperfusion. Is this consistent with our case that there is left ventricular systolic dysfunction due to chronic ischemia, and when you did the CABG surgery, the after the myocardial reperfusion, the left ventricular ejection fraction improves.
Yes.
Yes.
Okay,
Yes, it's hibernating.
okay, okay.
So, doctor, where do you
And
see? Where do
in
you see?
stunting, in
Where,
stunting there is brief acute ischemia. In the hibernation, there is chronic ischemia. The adaptation is different to different stresses. Okay. Okay. So what is your question?
yes, doctor. So, where do you see this ischemic preconditioning, and what's the significance of it?
The ischemic preconditioning thing is a thing. It is to adapt the cells to the ischemic condition. They become much more adaptive to the if the patient goes into if an angina patient goes into MI. Okay, so now the cardiac cells have a much longer lifespan during that MI. Okay, he will be able, the cells will be able to survive the ischemic attack for a much longer period of time because of this preconditioning. Like if you went on to a summit to climb K2 or Mount Everest, but you have stayed on the mountains for preconditioning to precondition yourself for 2 to 3 weeks before going on to the summit. You will be much better better in facing the conditions during that summit. But you have went from the United States directly to the base camp, and from the next day you started the summit. You will not be as better to as you will not be much better as compared to that person who went on to the base camp, stayed there at the base camp for 2 to 3 weeks, then started the summit. Okay, so there is a
Yes.
preconditioning that improves the chances of survival. Okay.
Yes. So, doctor, here the scenario shows that there is a chronic exertional angina. So, there is a chronic is decreased blood flow is there. So, doesn't it causes that ischemic preconditioning?
No, but now see the other phenomena. First there's a decrease. There is a decrease in the ejection fraction. After the decrease, we gives the when we do the CABG surgery, the left ventricular ejection improves to the 50%. Pre-ischemic conditioning does not explain these phenomena.
Yes.
Okay,
Okay.
ischemic preconditioning does not explain why it's improved from 35 to 50 after the air cabbage. That it is not explained by ischemic preconditioning. The only phenomena we can explain this is through hibernating myocardium.
Okay, doctor.
Okay. Okay. Which of the following is the most likely cause of this patient's symptoms? Okay. Which of the following is the most likely cause of this patient's symptoms? Okay, see the question. Okay. 42-year-old man comes to the emergency department for evaluation of chest pain. Now see all the abnormal findings of these patients. Moving furniture in her summer hours 2 days ago when she experienced sharp pain in the left side of the sternum. Okay. Okay, the chest pain. And what are the characteristics of the chest pain? Sharp pain. Location, left side of sternum. Okay, they had that episodic pain. And there's a clear linkage with deep inspiration.
Yes. Inspirations.
Yes, deep inspiration or trunk movement as well. History of hypertension, okay. Am I at the age, my father, okay. Blood pressure is elevated. Localized tendon. Localized tenderness as well. Where localized tenderness? Palpation at the left sternal border. Okay. Which of the following is the most likely cause of this patient's symptoms? Now you have to find a diagnosis which can explain all of these findings. Okay. Can GERD explain the localized tenderness? Here? No. Panic disorder? No. Esophageal spasm? Esophageal spasm does have causes? No. Pneumonia? No. Pulmonary artery hypertension? No. Unstable angina? Acute pericarditis? The pain of the MI, is it sharp or not sharp? Or is it diffuse? Diffuse or sharp?
Diffuse.
Diffuse pain. It is not sharp pain. Okay. Okay. And it is not going to cause localized tenderness, and that inspiration has nothing to do with trunk movements.
Mm.
Okay. That pain has
Yes.
nothing to do with the trunk movements. Okay. Same goes for the aortic dissection. Acute pericarditis pain does increases with deep inspiration, but even the acute pericarditis pain has nothing to do with trunk movements. And the second thing, localized tenderness at the left sternum border, that cannot be explained by the acute pericarditis pain. Acute pericarditis pain is sharp. It is linked with the deep inspiration. It is gay, but that cannot explain the localized tenderness. The only thing that can explain is costochondritis. Okay, that checks all the boxes of this pain. Okay, okay, costochondritis checks all the boxes. Okay, it is a persistent pain which works with movement or change in position, often follows a repetitive activity. Okay. Okay. Okay, let's move on to the next one. Okay. Brought to the hospital due to sudden onset chest pain and nausea. Okay. Sudden onset chest pain and nausea. Medical history: diabetes mellitus, blood pressure has decreased, lungs AP is decreased, JVP is elevated.
Yes, inferior wall MI.
S ST elevation in 2, 3 AVF. Chest X-ray is in inferior MI. Inferior wall MI.
Means right
And
ventricle.
yes, right ventricle. See the pulse. Pulse is 60. In pulse is 60.
Involvement of AV nodes.
Okay. Yes. With complete occlusion of the proximal right coronary artery. Okay. Patient is persistently hypotensive in the cardiac. Okay. So what is happening in this patient? The inferior wall MI, which is
Post
leading to the
MI
right ventricular.
cardiogenic shock.
Okay, the patient is a cardiogenic shock. There is an inferior wall MI. Okay, 2-3 AVF leading to right ventricular dysfunction. Okay, due to which the patient right ventricular is no longer working. Okay, and due to which you are going to see jugular venous pressure also going to be elevated. The patient has jugular veins distended. Okay. Okay. What will happen to the cardiac output?
Decrease.
Cardiac output decreased. Okay. What will happen to the central venous pressure? Jugular veins are distended. The pressure within the veins is going to
Increase.
increase to decrease. Increase. Option number.
Increase.
Okay. Which option is going to be the right answer? B.
B.
Okay.
Left heart is okay.
Okay.
Only the right
Yes.
heart is very.
Because the right heart is the one which is affected here. So the blood is no longer moving into the left heart, and the pressure within the left atrium is going to be normal or decreased. Okay. If the left side is affected, you are going to see bibasilar crackles, pulmonary edema. But if the right side is affected, you are going to see jugular veins distension. Okay. Which of the following is the immediate cause of death in this patient? Okay, so this photo represents coronary atherosclerosis. Okay, so there is an there is the complete obstruction of the coronary artery here. You can see here. "30 minutes prior." Okay. The patient develops MI 30 minutes prior. What complications can arise within 30 minutes?
VFib within 1
Ventricular
hour.
fibrillation.
Ventricular fibrillation. Arrhythmia.
Arrhythmias arises. Cardiac arrhythmias arises first few days to several months. Okay, this is the first complication which you are going to see in the important cause of death before reaching the hospital and within the first 48 hours post MI. Okay, cardiac free rupture, a free wall rupture does not occur within 30 minutes. Okay, embolic stroke can lead to the a stroke and these symptoms, but not here. It is not embolic stroke is not a cause of death here. Regional contractile dysfunction cannot lead to death. Septal rupture does not occur within septal rupture occurs at what time frame? Ventricular septal rupture
Within 5 days.
3 to 14.
within within 3 to 14 days. Okay, 3 to 14 days. 3 to 14 days. Intraventricular septal rupture. Okay. Between AFib and VFib, which is more deadly? Which causes
VFib.
the death? VFib is the one which causes the death in this patient. AFib does not lead to death. Okay, it can lead to strokes and the formation of emboli
Thrombus.
and
Thrombus.
embolism, thrombus. Okay. Treatment of these patient symptoms will include which of the following strategies? Okay. Now let's see all the abnormal finding in this patient. Then we will see which diagnosis can explain all those findings. Progressive distension and tightness in her right lower extremity. Right lower extremity. It is not the distension and the is in the both of these feet. It is like asymmetric. Okay. Progressive distension. She has no shortness of breath, fever, rash. Patient was diagnosed with melanoma of the right thigh. Melanoma of the right thigh. Diagnosed 2 years ago. Melanoma 2 years ago. And underwent surgical resection. Two of her inguinal. Okay, you can see that they clearly are linked. Melanoma is on the right side. Right lower extremity is distended. Okay, and the lymph nodes of the right sides are removed. Lymph node of right side, inguinal lymph nodes of the right side are removed. Okay. She subsequently underwent inguinal lymphadenectomy. Okay. No evidence of recurrent malignancy. Why there is a swelling in the right lower extremity only? Why there is swelling on the right lower extremity? On the right, only on the right. What is the cause? Okay, tell me what is the cause here of the extreme of the edema of the right lower extremity?
Venous
Lymphatic,
This
obstruction.
lymphedema.
lymph, lymphatic obstruction.
Lymphodema,
Yes.
lymphatic obstruction, because we have removed the lymph nodes, the major lymph nodes, two inguinal lymph nodes, which are involved in the draining of the lymph from that extremity. That's why it is not heart or anything or any other cause. Because if it is heart, why only the right side is involved? Why not the left side is also involved? Because there you can clearly see there is a link between the surgery and the development of that edema. Okay.
Yes.
So which one is going to be the right answer? If it is the
Compression.
lymphedema,
Compression to increase the lymphatic flow.
Yes.
Compression.
compression
Tight
to,
stocking or compression of the increased lymphatic flow.
yes, that is going to increase the lymphatic flow, which will improve the patient's symptoms. Okay. Okay. Blockade of estrogen receptors, no. Dissolution of intestine, there is some information here. Okay. It is lymphedema. Okay. Given the patient at highest risk for which of the following complication? Okay, these needle-shaped clefts. This is common to
Cholesterol.
what? Yes.
Cholesterol cleft.
Yeah,
Emboli.
these clefts. Okay. 72-year-old man comes to the emergency department due to sudden onset severe abdominal pain. Okay, accompanied by nausea. He has a history of coronary artery disease and recently underwent coronary angiography. Recently underwent coronary angiography. Now let's see whether or not the whole presentation supports our diagnosis of cholesterol emboli. Okay. Does recent angiography has any relationship with the
Yes.
uh, okay.
Yeah, atherosclerosis.
Okay, and there is a current smoker with a 30-year-long history underwent emergency laparotomy. Segment of small intestine is resected. Okay. On microscopic examination, there are several large caliber vessels with needle-shaped cholesterol clefts in their lumen. Cholesterol emboli have the high risk of causing end organ damage, and which specific organ is much more susceptible to the damage done by the cholesterol emboli.
Kidney?
Kidney, I think.
Kidney, kidney.
Renal artery stenosis most of the time they go there. Or if
Okay, they can
sometimes
lead
the
to
access is in the femur, that time sometimes it go to the distal means the dorsal fingers also necrotic changes during PCI.
yes. Okay, these can affect the small arteries and then can affect the glomerulus, can lead to acute renal failure. They can lead to gut ischemia. Our patient has gut ischemia due to cholesterol emboli. They can lead to livedo reticularis as well as cerebrovascular accident. They cause acute renal failure. Acute renal failure, not the kidney stones, not septic arthritis, not myelosuppression, not pulmonary infarct. Okay, kidney injury. Other than kidney injury, what other complications can it leads to?
That
Yes,
is, yeah.
mesenteric ischemia, also obstruction, and also
Digital ischemia as well.
yes,
Yes.
limbs ischemia, lower limbs ischemia.
Small arteries, only small arteries
Yes, distal is fallen.
may follow invasive vascular procedures, angiography, angioplasty, and grafting. Does our patient has an angiography?
Yes.
Yes. Which of the following best explain the observed findings? Medical history includes hypertension, type 2 diabetes, is an active smoker, that undergoes dopamine infusion with simultaneous cardiac imaging. Before infusion, normal left ventricular contractility, ejection fraction 60%. During the infusion, decreased apical contractility, ejection fraction 45%. 5 minutes after infusion, normal left ventricular contractility, ejection fraction 60%. Okay. Why we are seeing a decrease in the ejection fraction after the addition of dubutamine?
This drug-induced stress test, when they give the dobutamine, it increase the heart rate and increase the ischemia that is already compromised.
If it is MI, what changes are you going to be seeing here?
In MI, what's
Ejection fraction will
irreversible?
increase.
Irreversible.
Decrease ejection fraction. Yes.
And that will
There will
be
be
after,
irreversible
So
ischemia.
after do vitamin it will increase. Ejection fraction
yeah,
will increase.
like if it decrease from 60 to 45, it will remain 45. Okay. If it is a MI or something, okay. Okay. Normal myocardial is it a normal response? No, right? It shows there is a
No,
potential
that means there
ischemia.
is ischemia.
Yeah, there is ischemia. A focal myocardial, no. Option number A, coronary artery occlusion due to a plaque rupture and thrombosis. It is not MI. So option number A is eliminated. Okay, option number B or E. Which one is going to be the right answer? B or E?
E. Option E.
Supply demand, because the patient who cannot do the treadmill, they are going for this dobutamine infusion, and when they increase the heart rate, it will decrease the supply to the myocardium.
Because there is stenosis and there is less coronary blood flow. So they
And
need more
the supply
oxygen.
is fixed, but with tachycardia increase the demand. That's why there is this supply
Yes.
demand mismatch.
Supply demand mismatch due to fixed stenosis leading to this stable angina. Okay. So there's a supply demand mismatch due to fixed stenosis. It is not coronary vasospasm. Okay. Because the dobutamine does not lead to coronary vasospasm leading to decreased blood flow after the addition of dobutamine. Dobutamine does not lead to coronary vasospasm. Okay. It is pharmacological stress testing. Okay. Where the blood flow to the ones which have already decreased is decreased much more, and because it is shunted away towards those vessels which have increased blood flow. Okay. Which of the following characteristic of the right ventricle compared to left ventricle best explain this echocardiography finding? Okay, what has happened in this patient? So the patient has an STEMI, okay, has a MI, right dominant and thrombotic proximal right coronary arteries, which supplies blood to the patient's right ventricle, inferior and posterior. Okay, so he is asking that the patient has STEMI, and in STEMI, both right ventricle and left ventricle are affected. We did cabbage, and after cabbage, right ventricle function is normal, but left ventricular does not improve. Why this is? Why the K? Why the right ventricular function improved much faster than the left ventricle? What is the cause?
Because it is supplied both in systole and diastole.
And diastole, left ventricle only during diastole, so more prone for ischemia.
Yes.
Yes. Uh, why it is supplied in both systole and diastole? Why the right side is supplied in the both?
Increase wall stress in the left ventricle.
Because less pressure.
Yes,
Okay.
because of the less pressure.
Okay.
Left
See
work
the
has
yes. See the pressure on the right side. 25 systolic and diastolic is 5. What is the pressure on the left side? 120 by 120 by 12. And on the right side, 25 by 5. Because there is less pressure in the ventricles, they are going to be cause less obstruction of the coronary arteries during the systole. Okay. The relatively low systolic pressure allows the coronary perfusion throughout the cardiac cycle. Okay. Usually in our body, when the heart contracts, the cells get the blood supply, right? But in our heart, when the heart contracts, the heart does not get the blood supply. When the heart relaxes, then it gets the blood supply. It is opposite in the heart. Okay. Okay. So when the so because in the left ventricle the pressure is much higher as compared to the right ventricle, the blood flow is only during the diastole in the left side. But on the right side, it is both in the systole and the diastole. Okay? Okay, which leads to the improvement, this factor leads to the improvement in the right ventricular dysfunction at a much higher rate as compared to the left ventricle. Okay? And on the right side, the collateral circulation is much more developed. Okay. And the right ventricle oxygen extraction. The right ventricle oxygen extraction is also low because it did less work. Why it did less work? Because it is pushing against a circulation system which has less pressure. Okay. So right has less oxygen extraction, not higher. Improved collateral circulation and perfusion during both systole and diastole. Because it has less pressures. Okay, it has less 25 by 5, 25 by 8. Okay, so the right answer is E. Okay, let's move on to the next one. Which of the following most likely contributed to this patient's death? Okay. 3-day history of intermittent but progressive substernal chest pain, hypertension, lipidemia, poor adherence, ST elevation, pathological Q lives, and STEMI 3 days. Severe dyspnea, sweating, hypotension. On the fifth day, there is hypotension. What complication of MI can occur on 5th day that can lead to hypotension?
Tamponade?
Capillary muscle rupture.
Hypotension plus raised jugular venous pressure, no murmurs, no heart sounds.
Tamponade.
It's tamponade.
And this triad is okay. Okay, so the patient has what? Cardiac tamponade. Why the patient has cardiac tamponade? Why cardiac tamponade develops in this patient?
Free wall rupture.
Free wall rupture.
Yes,
Yes,
due to
free
the
wall
free
rupture.
wall rupture. Yes, free wall rupture can lead to cardiac tamponade. Okay, so dilation in the pericardial space. Yes. Which of the following cellular is more directly involved in the formation of fibrous formation of the okay. In the fibrous portion? What portion? In the fibrous portion of the patient plaque. Which of the cells is directly? Endothelial cells are involved in the early stage, forming in the fatty streaks. Okay, now we are left with activated platelets. In the fibrous plaque formation, in the conversion from the fatty streak to the fibrous plaque, what cells are involved?
Smooth muscle.
Muscle.
Smooth muscle cells. What answer is would be? Smooth muscle cells. Very good. Smooth muscle cells. Which of the following is most likely accounts for these observed microscopic changes? Okay. So there is the yellow brown pigment here. The yellow brown pigment. Can you see this pigment? Can you people appreciate this
Yes.
pigment?
Yes, sir.
Yes.
Okay. This yellow brown pigment. There is a specific name for this pigment.
Yeah, it's lipofuscin.
Lipofuscin.
This is lipofuscin is seen in is explained somewhere here. Fuscins. Oh, here. A yellow brown wear and tear pigment. What is the age of our patient? Associated
70.
with normal aging. Composed of polymers of what? Lipid and phospholipids. Complexed with protein. May be dried through lipid peroxidation of what will be the answer here? Autopsy of older adult will reveal deposits in the heart. Okay, so it is for Pushkin. Okay, and what is it? What will be the answer here? Lipid,
Option
glucose,
D.
D.
Peroxidation.
polymers of lipids and phospholipids. Okay, it is a polymer of lipid, phospholipid. Development of these vascular lesions most likely involves growth factor released by so the following.
So, doctor, how lipofuscin is different from the transthyretin that we see in old age also?
Transthyretin is amyloidosis pigment, is a pink waxy material, and it is yellow brown pigment.
Yes. Okay.
Okay,
Yes.
it is pink, and this one is yellow brown.
Yes. Okay. Got it.
Development of these vascular lesions would most like. Okay. Okay. Involves atherosclerosis involve what growth factors? PDGF and PFGF. PDGF means platelet
Platelet derived growth
derived,
factor.
and FGF
Fibroblast.
fibroblast growth factors. Is there is fibroblast in the options? Is there is fibroblast in the options? No.
No, sir.
Is there is a platelet in the option?
Yes.
Platelet derived growth factors. So the patient is of atherosclerosis, and atherosclerosis involve two growth factors, FDGF and fibroblast growth factor. Okay. High intraplaque activity of which are the most likely results in? Okay. Which of these activity is linked with increased risk of plaque rupture?
Metalloproteinase. See.
Prolyl hydroxylase. Prolyl hydroxylase is the one which is involved in the formation of collagen triple helix.
Collagen, yes.
Pro-collagen peptidases convert pro-collagen into collagen. Lysyl oxidase is involved in the formation of
Crosslinks. Yes.
HMG. Option number A is involved in the formation of what? HMG CoA reductase.
Cholesterol.
Cholesterol synthesis. Okay, it is involved in the cholesterol synthesis. Okay. Which of these is most likely to be involved in increased risk of complication is metalloproteinases. Okay. That is involved with the increased risk of fibro of atherosclerotic plaque rupture. Okay. Is a photo of thin fibrous caps. Okay. Because this is a stable one, this is the unstable one. Numerous macrophages and macrophages are involved with the macrophages activity is directly related with the metalloproteinases is activated. Okay. Transient myocardial ischemia causes myocardial cells to increase in size. This effect is due to what? Due to in part of which of the following? Net cellular solute loss, cascade protein phosphorylation, high cellular bicarbonate content.
Sodium potassium ATPase pump won't be working, so there might be increased intracellular capless accumulation.
We see this platelet derived growth factor is secreted by platelets and macrophages. Okay, and this is the one which is involved in the the one question we have done earlier. TGF beta is involved in fibrosis. Okay, this is involved in fibrosis, induces smooth vascular remodeling, smooth muscle cells migration. Metalloproteinases involved in tissue remodeling. Okay. Mm, okay. How does this? Why the cells swell when there is low when the ischemia develops? Because during ischemia causes decrease in oxygen supply, decrease in ATP formation, and ATP dependent channels are going to stop working. And in those, the first one is the sodium potassium ATPase. And what is the function of sodium potassium ATPase in the cardiac cell? Is that is used to regulate the calcium content. Do you know the how does the digoxin works? How does digoxin works?
It inhibits
It
the sodium
enables
potassium ATPase and indirectly the calcium and sodium exchange, I think.
Yes, and when it inhibits, what happened to the calcium content?
Intracellular increases calcium.
Intracellular increase. Decrease ATP, decrease activity of calcium, sodium, potassium ATPase from cellular swelling. Okay, cellular swelling. Okay, so the cause of cellular swelling here is increase intracellular calcium accumulation. Okay, in the cardiac cells. Okay. Which of the following is the most likely cause of this patient's current condition?
Dr. Hasnan, how will increased calcium level cause increase the size?
So why
More
can't it be
solutes,
potassium, sir, since the pump is
more
also not working?
okay, okay, let's first, when more solutes are inside the cell, what will happen to the water?
It will go inside too. All right.
Water more, okay, it is going to cause swelling. Okay, okay. The sodium potassium ATPase normally brings potassium into the cell and in exchange for sodium. In the in cellular potassium accumulation, sodium potassium ATPase moves potassium inside the cell. It moves it inside the cell. If it is not working, what will happen to the intercellular potassium? It is decreased. It is it is decreased. Okay, not
Okay, sir. Yeah,
increased. Okay.
yeah, sir.
Which of the following is the most likely cause of this patient's current condition? Okay, let's see what is happening. Age 63 in Kafi. Hospitalized for a urinary tract infection, coronary artery disease, history of coronary artery disease. Takes aspirin, clopidogrel, atorvastatin. His medical condition includes type 2 diabetes. Blood pressure is decreased. Pulse elevated. Elevated right arterial pressure. Decreased the left arterial pressure. Okay. What type of shock it is? What type of shock can
It's
explain these two findings?
Septic.
The right
Septic.
ventricular septic shock. Do you think in
Septic.
septic shock you are going to see increased right arterial pressure but decrease left arterial pressure? Why in septic shock there is a difference in the right and left atrial pressures? Why the right atrial pressure is elevated in septic shock? Can you explain? Can you defend your answer? If you go with the
It should be
septic, if you say it is septic shock, then why right atrial pressure is elevated?
it
In
should be
septic
low
shock,
because
yeah,
It
it
should
should
be
be low.
cardiogenic.
It is cardiogenic shock, and what specific cardiogenic, right or left?
Right, right.
right.
Right, right sided cardiogenic shock. Which of the following areas of colon? Okay. Okay, he is asking us about
Clinic.
the watershed areas.
Hmm.
During ischemia, the first areas that is going to be get damaged are the watershed areas. And what are the watershed areas in the GI tract?
Splenic
Panic,
fracture.
Planic fracture.
Splenic
Other
fracture and
rectum,
and splenic fracture and the
rectum,
Hepatic flexion.
Between the superior and
Cecum.
middle colic arteries.
Planning flexion.
one is
Where
splenic
two
fracture.
vessels.
Yes, where there's two vessels starting to get anastomosed. These areas are located at the borders of the major arteries. Okay. Splenic fracture and the rectosigmoid junction. Okay,
yes,
rectosigmoid junction. So the answer is going to be splenic fracture. Okay, these are the one which are going to be affected. Which of the following vascular body is most likely to carry the highest atherosclerotic burden in this patient? Okay, atherosclerosis is very common in first in the abdominal aorta. After abdominal aorta, which vessel? Coronary artery.
Coronary. Aortic crocodiles are popping from the car of wells.
Yes. Okay. Then, if this trend is followed, which answer is going to be the right answer?
Coronary.
Coronary.
Very good. Coronary artery is going to be the right answer. Okay. The murmur heard during the initial presentation is most likely explained by a pathological process involving which of the following structures? Within 2 hours of chest pains, as it lower sternal is never had similar type today. Basilar crackles are present and systolic murmur is heard. Okay. Okay, and after the cabbage, after the stunt placement, the patient murmur has removed, has gone, and the lungs are also clear to auscultation, and there is no heart murmur. Okay, but the murmur appeared due to what pathology? Why does the murmur appears? And that murmur gone away after the blood supply, after there is reperfusion.
Mm.
If the patient has what murmur? Mitral regurgitation murmur. And why that murmur develops? Due to the ischemia of the
Papillary.
papillary
Papillary
muscle.
muscle.
Okay, and due to that ischemia, and when after the stent placement there is reperfusion, the murmur disappears. Okay, because now the papillary muscle starting to work normally again. That leads to the a normal function of the mitral valve, leading to the absence of that murmur. Okay, it is not due to the aortic valve, aortic roots, interventricular septum, not to the chordae, to the papillary muscle. Okay.
Sir, can you
And
please repeat previous?
the patient has MI, develops a murmur. Cause of murmur, decreased blood supply. What? To the papillary muscle. Papillary muscle is attached to what? By chordae tendineae to the mitral valve. Now what happens? There is a murmur due to because now mitral valve is not working normally. Then you did stent. Then you place a stent. There is reperfusion, and due to reperfusion, the papillary muscle function restores. Papillary function restores, and murmur is gone. And he is asking why the murmur is gone in this patient. Because papillary muscles has now again comes to the normal. Okay.
Okay.
At the time of patient death, light microscopy of the affected myocardium will most likely demonstrate which of the following changes. A patient dies 2 hours after the onset of the symptoms. Within 2 hours, the symptoms 2 hours. Okay. Collagen scar does not available formed in 2 hours, right? Scar, 2 weeks to 14. Granulation, macrophages, granulation tissue, 3 to 14 hours. Okay. The macrophage. Okay. Neutrophil infiltrate 1 to 3 days. Neutrophils infiltrate 1 to 3 days. Okay. Dark eosinophilic stripes that occur in reperfusion injury. No. Okay. Edema, hemorrhage develops after 4 to 24 hours. After 4 to 24 hours. Our patient dies within 2 hours. Not in the 4 to 24 hours. Okay. So no edema, no hemorrhage. What will be the answer? What will be the answer?
It's normal. It's normal. Normal.
Normal.
Normal. Very good. Okay. So this is all for today. Okay, class. Okay, class. So this is all for today. We will meet you tomorrow. Okay.
Dr. Asnan, please share the ID.
Thank you.
Hello? Hello? Hello?
Hello, Margaret.
Yes, dear. Did I finish?
And that's what I'm thinking because everybody is leaving the class.
When we at work, I hide my phone because I was taking report.
Hey, yeah. I was just discussing with a friend. I didn't know what he said lastly. So, but it's like some people are coming in again.
I don't understand.
Same with me because it's supposed to be a 3 hours class, you know?
Yes.
You know, sometimes when he finishes a block, he has to generate another one and then start all over again.
Okay, maybe it's generating. But how many people are there? We are only 4 here.
We're only 5.
5.
Yeah.
I think the class stopped.
I think so because you know we used to be more than
Oh, when I was
30.
there. There were 50.
And yes, we used to be sometimes 50, 60 something. So I think it has ended because
I think so.
he just sent the ID.
Okay, dear.
Let
Oh,
me
my
just
dear, how are you
go.
doing? Did you take the immunology assessment?
No, I'm just saying I had a very busy weekend. I haven't even seen it.
Me too.
You want to
Oh, me
take
too.
it? They
I'll take
posted
it.
it already?
They did. I'll
I'm
take
going
it.
to
Yeah.
look at it.
Mm-hmm.
I'm going to
Mm-hmm.
look at it and take it.
Oh,
So
are we going?
let's just leave. If they are going to do
Okay, go
anything, they'll
ahead.
text
Okay,
it
dear.
back.
All right.
Thank you
Okay,
so
bye-bye.
much. All right,
Bye,
bye.
dear.